When the system works, a hospital feels like a promise. You walk in, you get a wristband, someone in a clean coat appears sooner or later. When it breaks, the building turns into a hallway full of people on chairs, floors, and stretchers that do not move. Every monitor screams. Every bed is full. There are more bodies than hands. At that point, the question is not who needs help. Everyone needs help. The question flips to who gets help first, who waits, and who never leaves the hallway. Those choices do not happen in a movie voiceover. They happen in quiet, fast rules that most people in the room never hear. This is about the hidden triage rules that decide who lives when hospitals overflow, and what it looks like from your side of the curtain when someone starts sorting lives on purpose. Most people think triage means the worst off go first. That sounds fair. It is wrong. Triage does not ask who is the sickest. It asks, where does one unit of time and gear save the most lives? If one person needs 10 minutes and a simple drug to walk out, and another needs 3 hours, a full team, and luck just to have a chance, the math pushes care toward the 10-minute case. Not because anyone loves the other person less, because in a flood, time and gear are more scarce than compassion. Triage is not treatment, it is sorting. You are not on a hospital show where the camera follows one hero doctor. You are tiles in a moving puzzle. People land in rough bands. People who will live even if nobody touches them for a while. People who will live if they get help soon. People who are already gone, but nobody has said it yet. The middle band drives everything. That is where effort still has leverage. When a hospital overflows, triage is the moment someone with a clipboard or a mental checklist starts looking at each body and quietly deciding which band they fall into. From your side, it can feel personal. They walked past us. They did not stay long. They never came back. Inside their head, it is ratios and survival odds measured in minutes, not feelings. Next, we walk through the kinds of things that bump you up or down that invisible list when the hallways are full and the staff are counting more than heartbeats. When things overflow, staff are not flipping coins. They are running fast math in their head. Rule 1, time versus payoff. If a nurse looks at you and thinks 10 minutes and this person walks out, you move up.
If they think 3 hours and maybe they live, you slide down behind the fast wins. Short, effective jobs come first. Stop heavy bleeding. Open an airway. Give a drug that reverses something simple. Anything that turns a dying person into a stable one with a small push. Rule 2, fixable versus not. Some damage is reversible. Some is not. Someone with low blood sugar who can drink and talk is a fixable case. Someone with a blocked airway that one maneuver can open is fixable. Someone with massive brain injury and no signs of response is mostly not. If one bag of fluid changes your blood pressure from awful to okay, you look like a good bet. If 10 bags will not move it, anyone looking at the monitor thinks too late and moves their attention toward other beds. Rule 3, walking, talking, breathing. Even in chaos, a quick look at how you move and speak says a lot. People who walk and talk clearly, even while hurt, are the later group. They get seen, but not right now. People who can answer simple questions and keep their eyes open are the middle band. People who cannot answer, cannot breathe right, or do not react to pain are the urgent or already gone band. If you can say your name, your age, what happened, and where it hurts in one breath, you buy the staff more confidence. You are easier to sort and to pause. That can mean you wait longer because you are not about to die this minute. Rule 4, age and reserve. Nobody will say it out loud in the hall. It still sits in the math. A healthy adult with one bad wound is a better bet for limited gear than a very frail person with 3 organs failing before they arrived. A child with a good chance of recovery pulls attention heavier than someone with no real path back. It is ugly. It is not personal. It is about who can bounce back if help shows up at all. Rule 5, resources per person. If a case needs 1 bed, 1 nurse, and 1 drug to flip from dying to stable, that is a low-cost save. If it needs a full team, rare drugs, a machine that is already busy, and an intensive bed that does not exist, that is a high-cost gamble. In Overflow, low-cost saves get priority. High-cost gambles get pushed back. Sometimes that means comfort only instead of full treatment.
From inside your chair or on your stretcher, this all feels like moods and luck. From their side, it is a fast, brutal question. If I spend 10 minutes here, how many people walk out of this building and how many do not? Next, we talk about what you do control, how you present, what information you give, and how not to look worse than you are when someone with tired eyes is sorting the hallway. You do not control the overflow. You control how hard you are to read. First, walk in as a clear story, not a mystery. Staff do not have time to pull your history out of you one slow detail at a time. You give them a short, sharp packet. Who you are, what happened, when it started, what is worst right now. I am 42, I passed out at home an hour ago, chest pain in the center. Short of breath, no big health problems before this. That tiny speech beats 10 minutes of I just feel weird and a life story about work stress. If you bring someone else, they are there to back you up, not to add drama. Their job is to give facts if you fade.
Second, do not hide how bad it is. People play tough at the worst time. They walk in shaky, sit quiet, and pretend they are fine because they do not want to bother anyone. Overflow triage does not reward polite silence. If you can walk but you are seeing spots, say so. If your pain is sharp and new, not dull and old, say so. If you took drugs or have conditions that change the picture, say them. This is not about acting weak. It is about not covering the signs they need to slot you correctly. Third, carry your cheat sheet. If you live in a place where hospitals might overflow, you do some homework on calm days. You write your key info on a card in your wallet or phone case. Name, age, allergies, main conditions, meds and doses, emergency contacts. In chaos, that card speaks when you cannot. It also helps staff move faster. Less time guessing and spelling, more time making decisions.
Fourth, look like someone they can help. That means you do not show up drunk, high, or in a screaming match if you can avoid it. Loud, wild patients do get seen, but often by security first. Every minute spent calming you is a minute not spent on your numbers. You can be scared and still be clear. I am scared, I think this is bad. Here is what I feel. It's a very different energy from yelling at everyone because the wait is long. Staff are human. They lean toward the patient who looks like a good use of their next 10 minutes, not a new problem in the hallway. Fifth, bring your own basics. In an overflow event, blankets, cups, and phone chargers vanish fast. If you have to go in and you have a moment, grab a small bag. Water bottle, phone and charger, basic snacks if you can eat.
Warm layer, your card with meds and history. You are not packing for vacation. You are removing small reasons to bother tired staff and small ways to crash while you wait. From your chair, it feels like nobody is doing anything. You see overworked staff walking past. You see other patients groaning. You see someone who looks worse than you get wheeled away, or someone who looks better than you get pushed ahead. Triage is ugly on the outside because the logic runs inside heads, not on walls. You are watching a quiet sorting game where the currency is minutes and supplies, not fairness. They are asking, who will still be alive in an hour without me? Who will not? Where does this bag, this drug, this room, this 10 minutes buy the most life? You want to believe it is about who deserves care. It is not. It is about leverage. The harsh truth is that in full overflow, some people get moved to comfort only in one mental tick. Not enough gear, not enough beds, damage too deep, odds too low. You might never hear that line said. You will feel it when your stretcher stops filling the doorway and starts filling a quiet corner instead. This script is not here to turn you into a triage expert. It is here to strip away the magic. Overflow care is not a promise. It is a triage line that stretches from the ambulance bay to the plastic chairs, run by people doing fast math with tired hands. You do not control the rules or the numbers they face. You control how loud your problem looks in their crowded field of view, and how hard or easy you make it to see you as a person they can still pull back toward the door you walked in through.